Want to introduce you all to Scott. Scott is the co-founder and CEO of Keen Insurance Services. At Keen, he is committed to building a company which delivers compassion, honesty, and excellence in supporting consumers navigating their Medicare experience. We'll pass it off to Scott.
All right, thank you. And great to be here with all of you today and make this a little interactive. Here I am. So really excited to be here today. Today we're going to help get you ready to make one of the most important decisions you will each year, which is about your drug coverage, which is part of Medicare. And right now, as of yesterday, we are in the Medicare Annual Enrollment window. Between yesterday and December 15th is the one time a year everybody can make changes to their Medicare plan. So you're going to start seeing, as you probably already know, tons of advertisements and maybe things in the mail and people calling you. So and this is a very big year for, in particular, changes to the Part D drug program. And so today we're going to start by just level setting. So we're all, using the same terminology to just describe how Part D plans work. And then with that context, we'll talk about the changes coming in 2025. And then we'll finish up with an action list of things that, I would suggest you do over the coming weeks to really make sure you're in a great position when we get to January. All right, so first thing we're going to do to make this fun and interactive, and I do encourage you to just throw questions in the chat and we'll hit them along the way or at the end. Let's poll the audience. So how do you get your prescription drugs today? Are you in a standalone prescription drug plan? Are you in a Medicare Advantage plan that has prescriptions built in? Are you getting it from an employer or VA? Maybe you don't have coverage, or if I didn't put the right answer up there in one of the selections, or you don't know, just say you don't know. And I saw this from some of the chat. Some people have the WellCare standalone plan, most popular prescription drug plan in the country. Some people have it as part of their Medicare Advantage plan. So it's going to be probably a mix. I'll keep talking and you can show the results kind of whenever they're ready. But just to set context, there are roughly 67 million Americans that have Medicare. Of that, 53 million have Part D coverage. And we've got a mix of folks with standalone plans, Medicare Advantage, employer, and VA. Right now, as of 2024, just over 50% of people get it from a Medicare Advantage plan. About 35% get it from a standalone drug plan. So, and that used to be the other way around, but over the last several years, Medicare Advantage is sort of nationwide has really taken off, and people who just have standalone drug plans and Medicare supplement plans, maybe that's gone down, but it's still, those are still two of the big predominant answers. Now, prescription, when we're talking about Part D prescription drugs, I should start by saying these are the drugs that you get at the pharmacy, that you take at home. These are not drugs that are given to you in the hospital, the injectable drugs. This is not what was considered to be Part B drugs. These are the things you get, at the CVS, the Walgreens, the Safeway, Walmart, Costco pharmacy. But this is a big deal. It's a big, costly program that the federal government pays for, and it's changing a lot this year. Second question, this is just sort of a fun question, but guess which of these 5 drugs is the most expensive? We got Januvia, Farxiga, Jardiance, Xarelto, and Eliquis. All of these, you may have seen commercials. These are some of the heavy hitters. And there's a reason for this. These are some of the most expensive drugs. that are taken by millions of Americans. The average monthly cost for these drugs in 2023 ranged from $517 up to $573. So and up until now, the Medicare has not been able to negotiate these prices. So, uh, uh, but the point is, like, there's a lot of people taking a lot of really expensive drugs, and those have to get paid for. Now, let's see if we can see. Okay, we got a tie between Januvia and Jardiance. The answer is Jardiance. So Jardiance is slightly more expensive than the rest. All 5 of these drugs are drugs that were in the first round of drug negotiations that the Inflation Reduction Act for the first time allowed Medicare to negotiate these very expensive drugs with the pharmaceutical companies. They picked these very expensive drugs just to pick on Jardiance because they have, really catchy commercials playing right now, and the song is stuck in my head. In 2023, Jardiance was used by 1.8 million people. The government spent $8.8 billion on Jardiance, and that is, that is of the $137 billion it spends on drugs. So we're talking about, this one drug is 15% of all the drug spend by the government. It's very expensive. The good news is we have negotiated that down from $573 a month to $197 a month. Bad news is that doesn't start till 2026. So you hear about all the drug negotiations that are going on in the Inflation Reduction Act. That is not impacting 2025. It is impacting 2026. But the point is, the reason this is really important, and the reason government took some of the actions they took this year, is because there are a lot of very, very expensive drugs, and people, were struggling to pay for these drugs, and that is one of the reasons why you saw some of the big changes coming this year. So just keep that in mind. It's not, a lot of people are just taking low-cost generic drugs, $5-10 a month, but there's a lot of these very expensive drugs that are getting paid for by our Part D plan. All right, some basics just to ground us. Part D, Medicare Part D, helps us pay for the drugs we get at the pharmacy. Part D is part of Medicare. So we have Medicare Parts A for services at the hospital, Medicare Part B for services when we see the doctor, get a lab test outside the hospital. But Part D, those A and B, they don't cover the drugs you get, these very expensive drugs or any drugs you get at the pharmacy. So Part D came out. And right now, in 2023, actually 2025, the estimate ticket for taxpayers, the government, is going to be $137 billion. And Part D, this year, most Part D plans, whether it's part of a Part D plan or a Medicare Advantage plan, the federal government is giving the health insurance company $157 per person per month that they can use to administer this drug plan and subsidize a large portion of the cost. So every time you're paying for drugs under your Part D plan, just know the government and through the subsidies they're giving the health plans are likely paying much, much more. And because we have so many of these highly, highly expensive drugs, and there are drugs that are $10,000 a month. There are all sorts of very expensive drugs out there. The government's on the hook. We as taxpayers are on the hook to pay for those drugs. These Part D plans are all private companies, private profit-making companies, which drive them to be efficient and so forth. But they have to make sure that there is appropriate use of the drugs, not irresponsible use of the drugs. Because if instead of 1.8 million Americans took Jardiance, 20 million people took Jardiance, that would break the bank. That would So it's all got to be balanced. And so what you see the reason why a Part D plan is structured the way it is, with all these pieces we're going to talk about, deductibles, copays, so forth, It's because they're trying to drive effective utilization. They're trying to make sure people who really need it are getting it. People who maybe could take something else that's less costly, they're taking that. So they're looking for value. These are the plans are paid for by the government, but every one of them is run as a private company. There is no federal Part D plan like there is Medicare A and B. And so what you see in a plan is they're going to have all these rules that dictate how you use the plan, how you get your benefits under the plan, and that is to drive this effective utilization. And they're rules about what cost share you pay, what you pay in certain circumstances, and there are coverage rules, which are rules about how you can get the drugs themselves. And the thing to remember is Medicare does not require these prescription drug plans to cover every drug. It only requires them to cover 2 drugs in each category. In many categories, there's 20, 30 drugs, and maybe they want to cover 20 or 30 of those drugs. Maybe they want to cover 10. Maybe they want to cover, if they can just cover 2, they're still a valid plan. So every one of these drug plans comes from a private company. Every plan is trying to make a profit. And every plan sets its own rules about what drugs are covered and what cost sharing and what coverage rules you have. And that's why like these plans can be really confusing because they can take on lots of shapes and forms. All right, so we'll talk about the cost sharing, then we'll talk about the rules, and that way we'll have level set on this topic. If I'm going too fast, if I'm using a term you don't use, just chat it to me. We'll make sure that we get it taken care of. So, there are a bunch of these terms that get thrown around when it comes to what we pay, our cost share, when it comes to a Part D plan. Premium, deductible, copay, coinsurance, out-of-pocket max. So I'll give you an analogy of how to think about this stuff. So I'm a dad. I got 2 daughters. They're 9 and 11, and we love to go see the Golden State Warriors play basketball. And we go maybe once a year. We watch it on TV a lot. And when we go to the basketball game, we have to pay different things for different things. So think of the premium is let's see a premium is what you pay every month. So and I think you're very familiar with the premiums. Some plans are 0 premium. Some plans are upwards of $100. And if you have income above certain thresholds, you pay additional income-related penalties monthly, and that's your premium. My analogy will start the next step, which is the deductible, the copays, the coinsurances. People get these kind of, they're just really easy to conflate. The deductible under the plan, that is what you pay before you get any benefits from the plan. So to me, that's like, in my analogy here, that's your ticket to the game. You've got to pay for the ticket to get into the game before anything else happens. It's a one-time fee. It's a one-time fee per year. But until you pay that ticket to get into the game, you're not in the game. A copay is where you pay a certain amount for something and it's fixed. So think of a copay as being like, let's say my kid won a coupon at their school to get any snack they wanted at the concession stands for $5. That's a copay. Any snack, $5. The rest of it is paid by someone else. Coinsurance, that's another kind of coupon. It's but it's more of a percentage coupon. So it's a 20% off coupon. You pay your 20%, they pay 80%, and then the amount you pay depends on whether it's some M&Ms or a double-decker cheeseburger and French fries. You'll pay a higher percentage. You'll pay more money if it's a coinsurance than if you have just a flat copay in these situations. And then the out-of-pocket maximum, uh, that's dad. So the girls may bring their money, they may bring their their coupons, but at the end of the day, they're going to run out of money, and above a certain threshold, once they've run out of money, it's going to be on me to pay for everything else. Uh, and just like you would have these, uh, features, it's the same thing. It's the same concept, and it's important to kind of understand these because these are how the health plans build the rules about what it's going to cost you and what drugs you're going to get. Um, the last thing to say is there are about 15 million Americans who are on a program called Extra Help. It's also called LIS, Low Income Subsidy. And that effectively makes a lot of these payments go away. It is for people who have incomes of 150% of the federal poverty level or less and certain asset limitations. Um, so for people who don't have the means of paying any of this, the government, and we do help those people. Again, that's probably 30% of people on drug plans are essentially not having to pay any of this or very little about it because they're on a subsidy program. Okay, all right. So that's the types of costs, the things that can take money out of your wallet. The other piece of the puzzle is the coverage rules themselves. And so we start with tiers. Most drug plans have tier 1 through tier 5. Some have a 6th tier. Tier 1 is your low cost generic drugs. Tier 2 is your more expensive generic drugs. So tiers 1 and 2, think of those as the generic drugs. Just some generic drugs are more expensive than others. Tier 3 will be for your lower cost branded drugs, which are more expensive, and your tier 4 will be for your more expensive branded drugs. Tier 5 tends to be a specialty pharmacy tier, and sometimes there's a special tier 6 for diabetes drugs. That's what you'll typically see. But the point is, different drugs are in different tiers, and each tier has its completely different set of rules. And it's important for you to know for the drugs you take what tier they're in and what those rules are. And you can learn a lot about that in this document called the formulary. Formulary is one of the most important documents to help you understand your health plan. The formulary, this is a 100+ page document that goes down through every single drug. It tells you if it's covered or not. It tells you what tier it's on. And you may have to pay different amounts based on the tier it's in. And it'll tell you if there are any special rules, like you have to get a prior authorization, or there's a quantity limit, or you have to try a different drug first before you try this drug. And then it's important to know that if a drug is not on your formulary, there is a process where you can appeal if your doctor sends the right documentation of the health plan and says, look, we've tried these other drugs that you cover, they don't work, we need this thing that is not on the formulary. They may make an exception, they may not, but if you're willing to sort of advocate for yourself, sometimes you can get special disposition here. And in this year, the amount you pay is going to be very different than it is next year in terms of your coverage phases. A phase means, well, if you have a deductible, you're paying everything until you hit that deductible. Then and right now there's an initial coverage phase, which is up to about $5,000, where you're paying on one system. There's the donut hole between $5,000 and $8,000, where you're typically paying 25%, and then above $8,000, the government pays everything. That's how it is today. It's going to be very, very different in 2025. But those are the basics. Those are the things that kind of, unfortunately, to keep in your head. And it's good to study this stuff. It's good to take notes. But all these things actually go into how to figure out exactly what is the best option for you going into 2025. And everybody's situation is different. It really depends on what drugs you take. Okay, so big changes coming in 2025. That $8,000 max out of pocket that I just talked about is going down to $2,000. That means that $6,000 that was previously paid by consumers on expensive drugs is now being paid by somebody else. And that has huge implications. Second, the drug deductible has gone up a little bit. The maximum drug deductible, that is, to $590. Because of the first two things, the cost sharing and the formulary are changing a lot. We'll talk about that. They are introducing payment plans this year for the first time. So if you have a big spike in cost at the beginning of the year, you can spread that out throughout the year. And there are a lot of gotchas and other plan terminations coming in this year. So I'm going to talk about each of these things, take our time to go through each of these things, and we'll dig in and again, ask questions along the way. And we will make sure that everybody's well grounded in this stuff. All right, since this is like such an important slide, I'm gonna take my picture off of the slide for a second. Okay, the max out of pocket being lowered to $2,000. This is a really, really, really big deal. And when you think about why you're seeing all the changes to, if you've gotten your annual notice of change, if you're seeing a premium increase, if you're seeing major changes to your drug plans, this is why. Okay. There used to be $6,000 that was on the backs of consumers. That $6,000 is now covered by the government and the health plan, and the government is paying a lot more, but health plans are paying a lot more. So this $2,000 max, it only applies. So that's the great thing. $2,000 is better than $8,000 in terms of how much you have to come out of your bank account to pay for your drugs in a given year. This $2,000 only applies to drugs covered on your plan. So if you're taking a drug that is not on the formulary of that plan, it's not on the list of covered drugs, and you spend $1,000 on that, that does not count to this $2,000. It's got to be things on your plans. This $2,000 does not include your plan premiums. So if you're paying $100 a month for your plan, or $0 a month for your plan, or 50 cents a month for your plan, none of that counts towards the $2,000. And this year, because that $8,000 has gone down to $2,000, we no longer have the concept of a donut hole. Plans are fairly simple, relatively speaking. The government has something called the defined standard. The defined standard is a plan that has a $590 deductible. And then after that, you pay 25% up to $2,000, and then you're done. Now, most plans are not based on the defined standard. Most are based on an enhanced standard, but the defined standard is out there as sort of the baseline plan. Most plans have a deductible somewhere between $0 and $590. And then instead of having a 25% co-insurance, they'll have a mix of co-payments and co-insurances of different levels, maybe more or less than 25% by different drug tiers. But the interesting twist, and this is something that I think it's going to take a while for us to get our heads around what this really means, but the government added this little wrinkle to the new program, which is that you get the better in terms of counting towards your $2,000. You get to count the better of what you paid under your plan, what you actually paid under your plan, or the defined standard. So what does that mean? That means if you happen to be in a plan that has no deductible, because plans can have any deductible amount up to $590, but they can have a plan with no deductible. And you take a $500, you have to pay $500 for a drug. But because, or you get a $500 drug, but you don't have a deductible, so you go straight to, say, let's say $100 copayment. So you actually paid $100. Well, the defined standard is a $590 deductible. If you had the defined standard, that first $500 would be out of your pocket. So guess what? You get to count that $500 towards your 2,000, even though you never spend it. Super confusing. It can work out really well in your favor. It can work out against you, but it's just something to know that when you start seeing the math of how these payments are actually calculated, it is incredibly complicated. It is complicated in a way that it is in your favor as a consumer, but it is going to be incredibly complicated to understand. And although the amount that the government is paying health plans to administer this monthly amount, has gone up a lot this year, from around $40 to this $157. If you include the demonstration program, which they added at the end to put a little more money into it. Ultimately, this above 2,000, that's risk that the health plan is taking on, and the health plan doesn't really know. The health plan is scared. They could lose a lot of money because they are on the hook for uncapped costs. And we will be recording this and sending this out, so I know this is a lot to digest. Hopefully this will get us through the basics, and I'll show you how to find this information for your plans in particular as well. So $2,000, or $8,000 down to $2,000, all that risk is shifting onto the health plans, and then they have to then get very thoughtful about how they design these plans so they don't lose a ton of money. And that huge shift in risk of that $6,000 that was previously covered by the consumers going on to the backs of the health plans and the government is why you're seeing so many fundamental changes to every aspect of the plans. It's a big deal. It's a great benefit to consumers. If you are a consumer that was paying $4,000, $5,000, $6,000, $8,000 out of pocket, this is the best thing ever. If you're a consumer that maybe takes one or two generic drugs, doesn't spend a lot, you're going to pay a little bit more. And so this is one of those things where we're making drugs more accessible to more people, but it's definitely a cost shifting, and it's just changing the way the game is played in terms of how the plans are structured. The next change that is big for the plans is that the maximum drug deductible is now $590, up from $545. But so the drug deductible, again, this is your ticket to the game. It's a one-time upfront cost, gets you in. And although a lot of plans could, in theory, charge a $545 deductible last year, most of them didn't. Actually, a lot of plans had no drug deductible, and the plans within MA rarely had any drug deductible. There are a lot of plans that had a drug deductible, but it would exclude tier 1 and tier 2. So you could get generic drugs, they're not subject to the deductible, and then you would have a deductible. And what you would typically see is maybe a plan with a very low premium would have a deductible. Sometimes that would be on tiers 3 and above, but you would still be off the hook on the generics. Maybe a plan with a larger monthly premium might have a smaller deductible. But what we're seeing this year in the plans that have come out is a lot of plans that did not have a drug deductible now have a drug deductible. A lot of them are at that max $590. A lot of drug deductibles that were $200 are now $590. So what we're seeing is the drug deductible being a major tool in sending some of that cost risk back onto the consumer. Now, the cap is still $2,000, but the deductible is enough upfront to make you think twice about whether you really need the drug. And for people who aren't paying attention and their plans roll into January, there's going to be so many people who get to the pharmacy, they go to fill their prescription, and the person in the pharmacy is like, okay, that's going to be $325. And they're like, what do you mean? It was in December, this was $5. Well, now you have a deductible. You didn't have a deductible before. Now you've got a deductible. That's going to happen, and so if you're talking to your friends, get the word out that it is super important for you to understand what's going on with your drug plan and shop it and not have a surprise when it comes to January, because in January it could be too late. Um, and like I said, this deductible, which is a fundamental way drug utilization is being controlled in these plans, oftentimes it will just apply to the more expensive tiers 3 or 5. But this year, it is going up a bit to 590. But the key thing here is like you're just seeing a lot more of it in plans, and a lot more of it at the max. It's being used a lot more. So be aware that that's what you have to pay even to start using your plan. It's significant.
There's
Um,
a comment from in the chat regarding the latter case. So you pay more to protect your position in case of a change in your health situation? Question mark.
so yeah, so uh, in the case where like a lot of times um, there's this question of like um, you know I don't take a lot of drugs now, but what if I have to take something that's really expensive? And you kind of have to, think about what's likely going to happen to you. You can pay a higher monthly premium. Maybe that will get you a lower deductible. Maybe that will give you lower cost shares. Um, the good news is you can switch once a year. So if your conditions change, you can definitely switch it. But it really comes down to like a personal decision and your ability to kind of forecast what might happen to you based on your family health history and your level of risk and so forth. But it's a hard question, and it oftentimes depends on what are the plans that are available in your market. Plans vary by service area. Most prescription drug plans have service areas at the state level. Sometimes it's at the county level. If they're embedded in a Medicare Advantage plan, it could be at the county level. Um, So, but I think the most important thing is you understand how it works, so you can kind of understand the trade-offs and do what you feel is right for you. Um, Also, because of this transfer of risk, the cost sharing has changed a lot. So the premiums have gone up. The government did put in place a last minute program when they saw the premiums were going to be going up a tremendous amount. They paid the health plans another $15 per person per month if they agreed to increases no more than $35 and to keep the premiums fairly stable for the next 3 years. Most prescription drug plan did participate in that, but still, you will see premiums increasing way more than they're decreasing. You're seeing those deductibles, and you're seeing changes to the copay and coinsurance. So it could have been a 20% coinsurance. Now it's a 40% coinsurance, and maybe tier 3 or tier 4. Copays can go up and down. So there's a lot of changes, and this is where it's really important to know how your current plan is going to affect you, and then when you look at other options, how those are going to affect you. And then finally, and this is going to be like the hidden killer, I think, for a lot of folks, uh, figuratively speaking, of course. But I think a lot of people are not going to look necessarily at exactly what drugs are covered. And one of the biggest levers the health plans have is to say, look, this drug is not covered. And so you'll see health plans this year, they'll have 2 or 3 products. They'll have a low premium product and they'll have a high premium product. And you look at one maybe has a $20 a month premium, one has a $100 a month premium. And you look at the 2 products, and you're like, okay, well, the deductible's about the same and the copays are about the same. What's the difference between the 2? The difference is the formulary. The difference is maybe one has 1,500 drugs on formulary, the other has 2,000 drugs on formulary. So even within an individual health plan, the drugs that are actually covered will depend on the plan. And so expensive plans may have more, expensive premium plans may have more drugs covered. It's really important you look at the formulary, see if your drugs are on the formulary for that plan, or you might want to think about, other plans. They may move drugs around based on tier. Tier 3 drug could become a tier 4 drug. And they're definitely doing more with the special coverage rules, which are things like prior authorization, quantity limits, step therapy, meaning you have to take one type of drug. It doesn't work before you can take a second kind of drug. But all these changes are just the health plans trying to come up with a way to create rules so that utilization doesn't skyrocket and unnecessarily. So we're going to now actually look at a real world example, and you can follow this pattern to understand your plan. So I'm going to switch gears to sharing. Two screens. Okay, so, all right, so there are two documents you just must get for your, whether it's your Medicare Advantage plan or prescription drug plan, to really understand the plan. And these are long documents. Don't be intimidated. I'm going to sort of walk you through an example of how to look at these documents. The first document is called the Summary of Benefits, and that is an overall document about the plan and the plan rules. And then the second document is the formulary, and the formulary actually lists the individual drugs, what tier they're on. So how do you use these two together? I've picked, this is the summary of benefits for a Medicare Advantage plan. Happens to be in my neck of the woods here in California. And although this also has the medical benefits built into it, the information about the drug plan start here on page 9. So here we go. For 2025, in this Medicare Advantage plan, the embedded Part D drug plan, all the information about the plan is right here. First, it says, okay, what formulary are you on? Well, they have multiple formularies because they have multiple plans. We are looking for the B2 formulary, and guess what? I've got the B2 formulary document right here next to it. So there we're good. We've got to match the formulary documents with the formulary on the plan, so you're at least looking in the right place. Okay, so let's see what we got here. A deductible, your ticket to the game. This one has a $590 deductible that you have to pay towards your drugs before you can use the plan, but it's only on tiers 3, 4, and 5. So you get immediate coverage for your generics. You have to pay the first $590 before you get a brand drug. Okay, great. Now, what do things cost us? And by the way, you can often save money by getting a 100-day supply of drugs or a 90-day supply of drugs. You can often save money by doing that at mail order. I'm not going to cover that right here because that's just another level of complexity. If you have questions, we could talk about that. But
One question here is the 590 deductible for each drug or a total for all the drugs for the entire year?
good question. The $590 is a cumulative total across all drugs once per year starting January 1st. So that's why it resets every year back to 0 on January 1st. And you could spend it all on one expensive drug, or you could spend it across lots of things and kind of build it up throughout the year. Great question. All right, you can see this is a 5-tier plan: low cost generic, preferred brand, specialty, non-preferred brand, specialty. And let's just say we're going to stick to your standard retail. When I go to the standard retailer, it's $2 to get my tier 1 filled, $12 for generics, 24%, 25%, 25%. Now, this is after the deductible. So in the initial coverage phase, you're paying the $590. After that, you can see you're paying a percentage. And percentages, anytime you see a percentage in a plan, it has to give you pause. And a lot of what we're seeing is a lot of plans last year had a fixed dollar amount. It's at $20, $30, $50, $100, but now it's a percentage. So you have to ask yourself, well, it's a percentage of what? Is it a percentage of a $500 drug? Because 25% of 500 is more than a flat, $50 fee. So be on the lookout for percentages, because percentages mean you don't have any predictability on the cost like you would if you just had a flat dollar coinsurance. But the plans are really simple now. There's not a donut hole. Usually you would have a chart, another chart like this for the coverage gap, which doesn't exist anymore. Basically, this is how you pay for your drugs until you hit 2000, and then you're good. Above that, you're in the catastrophic phase. You pay zero, as long as it's on your formulary. So in that sense, because we've gotten rid of the all those phases above $2,000, the drug plans are a little bit simpler this year. By the way, this is Aetna. Aetna owns CVS, so guess what preferred retail is? You go to their CVS locations or mail order, you're going to save a little bit of money, and it's always good to save money on these drugs. You can usually save the most money by getting, mail order. So okay, so now we know the rules. We know that if a drug is on tier 3, we pay 24%. If it's on tier 2, we pay 12%, or sorry, $12. But what about this? What about our formulary here? So let's ask ourselves, okay, well, there's thousands of drugs out there. What does my drug cost? That's when you bring up the formulary document, and you should ask the health plan
One
for the.
question before we dive into the formulary
Yeah,
is, would these drug prices increases change if you switch from Advantage Medicare to Supplemental Medicare?
they can absolutely change. The amount you will effectively pay will change, and what you'll see is. Aetna has a Medicare Advantage plan. It has a standalone PDP, just as an example. The cost shares will be completely different. All these factors will be completely different. The prescription drug plans, uh, the actuaries will say they have no place to hide, because in an MA plan, they're just trying to shift all the cost around. They can hide costs in other places, not in the drug plan. They can increase your hospital copay a little bit to balance the budget. They can charge a little more for what an ambulance costs. But a prescription drug plan doesn't have any of those types of things where it can hide or shift cost around. So prescription drug plans were particularly hard hit. They did get an extra $15 that the MA plans didn't get if they participated in the demonstration program, but it's still the plan. You got to take a really close look at these plans this year, because between that and the fact that supplements are going up a lot. I had a lady the other day who her monthly on her supplement went up $130 year over year. It's starting, you're starting to do the math, and this is where sometimes Medicare Advantage starts looking more attractive, but there's pitfalls along with that. We're not going to get into Medicare Advantage today. But yeah, you could take the exact same drugs, price it out for a United PDP and a United MA plan, completely different costs. It's definitely a great point and something to look out for. So let's go back to our. So here, this is the formulary. It lists all the plans that are in this formulary. Great. There's some important information up front that is just good to know, which is they say, by the way, this formulary can change any time during the year. So the formulary, if it's February, they can technically make changes, and they won't do it in many circumstances, but they will. They can. So it's not guaranteed. It's pretty solid, but it can change throughout the year. And so there's a little table here that explains different restrictions. So PA means prior authorization, means you have to get the prescriber to ask the health insurance company if you can take the drug. They have to provide medical information. You have to get it approved. QL, quantity limits. You can only have so much per month. Step therapy. You have to take drug A, prove that it doesn't work before you can take the more expensive B. So there are these rules that I mentioned earlier. They're all in this. And so that's where you find that. And again, it says if a drug is not on the formulary, you're on the hook for paying for it, 100%. Now, you may be able to ask for an exception. They may or may not grant the exception. It's much easier to just be on a plan that covers the drugs you want to take, because you're risking that, not being covered. All right, so that's the basics, and then it mentions we're going to mention the different tiers. All these drugs are going to be in one of these 5 tiers in this formulary. So, um, and this is what the table looks like. So if I just go, I'm going to do my old handy search, and I'm going to go to our Jardiance example, paste this in here. All right, so here's Jardiance. Jardiance is in the class. If you scroll up, you can see it's an anti-diabetic. And that's the little Jardiance song. It's lowering my A1C. That is diabetes control, sugar control. So Jardiance, okay, it's a tier 3. That's good in the sense that if it's a tier 3, I pay 24%. Although you know what, on this formulary, the tier 4 is only 25%. So it actually doesn't make a huge difference. You're essentially paying 25%. You're essentially paying that 25% that's in the reference plan that but sometimes you'll see tier 3 being 20% and tier 4 being 40%. Sometimes you'll see tier 3 being $40 and tier 4 being $100. It just depends on the plan. In this case, they don't make a big distinction between tier 3 and tier 4 because the percentage is only 24 and 25%. Sort of interesting. But you can see most of the brand drugs in this are on tier 3. There's a quantity limit for Jardiance. So if you had a doctor that was making you take Jardiance twice a day, you would run into problems here. And then MO just means it is available through their mail order. Let's pick another one. Let's pick Eliquis. Eliquis, also tier 3. There's a quantity limit, and it's available mail order. Great. I'll just look at one more. Xarelto. Okay. So they didn't really put much on tier 4, just because tier 4 and tier 3 are essentially the same price. And then tier 5 is their specialty tier. So here's an example of a specialty tier drug. And remember, tier 5, they also are doing 25%. So this is a plan. It's kind of dull. Maybe that's good. It's very close to the standard plan in that they're kind of giving you you pay about 25% across all these tiers until you get to the 2000. So I encourage you to get these documents and read them, and really research the drugs you're on, what you're going to pay for in your plan. And again, it's the summary of benefits and the formulary. Every plan has them. They use those terms. Those are the rules. Let's see here. Okay, good. All right. I'm going to go back to the other document real quick. And there's one more thing I want to tell you about that is super interesting and exciting for this year. And got to manually go through all my slides. Hello, 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 hello. Okay. One other brand new thing this year is the Medicare Prescription Payment Program, the MPPP, the M3P. And this is a brand new program that lets you spread the cost of that $2,000 out throughout the year. So if you had a deductible, you had a high cost drug, and maybe you were in a situation where you might have to pay $1,000 in January and $1,000 in February, you can sign up for the payment plan with the health plan. Once you sign up for the payment plan with the health plan, you no longer pay at the pharmacy. You walk away from the pharmacy, you don't put it in cash. The health plan is going to send you a bill. They do the math. If you owe $2,000 in January, they're going to divide that by 12, make 12 payments. You're going to pay throughout the year. It's really good if you're regularly taking really high cost drugs. It's not for people who don't spend a lot on drugs. I think, it's the first time they're rolling it out. They are educating the pharmacists about it. Pharmacists will hand you a pamphlet. They're supposed to, if you may be a good candidate for it. But it's you're no longer paying at the pharmacy. You're paying a bill to the health plan when they bill you. So it's good to know. It's good to know that this exists. You'll probably come across it, and if you are, you're spending a lot on drugs, you don't like to have to pay that all at the beginning of the year, it's a great program to look into. Question here, is there a consumer entity which evaluates which plans are better? Um, that's a good question. Like, I am a Medicare agent. I work for an agency. We have a policy of putting our consumers' interests first, and we, as agents, have really good tools that have all these rules in a computer, and we can get your drugs. We can run them through the system. We can do cost estimates. We can talk through this with you. You can also go to Medicare.gov. Say you want a plan, a drug plan. You put in your drugs. They'll do the math as well. And but Medicare agents like ourselves will hold your hand through the process as well, and help you kind of really understand it. And you don't have to understand all the terminology. But the Medicare.gov is a great source. You just say find a plan, put in your zip code, say you want a prescription drug plan, and it'll immediately ask you to add your drugs, and that's a good place to start. And there's some calculators for the payment plans as well, Medicare.gov. So really exciting development, not to add any more confusion to the year, but that will be a big help for some subset of the population, so be aware of it. A few other just sort of interesting tidbits. A lot of plans terminated for 2025. You might not get an annual notice of change. You might get a termination letter. 2 million people on Medicare Advantage plans, which provide a lot of the Part D, the plans are terminating outright. If you do not take action in January, you will be bumped back to traditional Medicare Part A and B, and you will not have drug coverage. So, and then many of the standalone prescription drug plans have also exited the market. Mutual Omaha completely exited the market. Some other carriers have exited the market. Some have really pulled back a lot. So some people thought taking on this $6,000 of risk is just too risky. We're not going to do it. They left the market. So, please make sure that your plan is even going to exist next year, because that's the worst case scenario. You have no coverage. If you are planning or you're currently getting your Part D you're working, you're eligible. You or your spouse is working. You're eligible for drug coverage through your employer. There's a rule that says, look, if you have employer coverage, you don't have to sign up for Part D. If it's as good as your Part D or better, you don't have to sign up. You will not be subject to the late enrollment penalty for signing up for Part D late. However, because this $6,000 is gone, these plans just got way, way more generous. Most employer plans will no longer count as equivalent. And if you're sitting there on an employer plan, not getting a Medicare Part D plan, you will be subject to the late enrollment penalty when you do enroll. Part D has a late enrollment penalty. Essentially, it's a 1% per month, 1% of average premium per month that you didn't sign up when you were supposed to, and that is a penalty for life. So if you are on an employer plan, about this time, you get what's called a notice of credible coverage from your employer. It'll say whether the plan is going to be creditable in 2025. And the last wrinkle, if you're interacting with agents out there, know that this year some plans went to no commission and or low commission, and that could influence what advice you get. In fact, WellCare, which is the #1 most popular prescription drug plan, they're famous for their $0 premiums. They went even further. Not only are they not paying brokers commission on new sales or retained sales, they actually canceled our contract. They said, you cannot service members. So we're in a tough position on the WellCare plans where we're not even allowed to really help people with them anymore. And I think it was a unfortunate thing, because the customer support that this is really paying for is really important in the year when there are so many changes, as we've just discussed. This is, there's a lot going on this year. Be aware, and definitely, get help if you need it.
There was also a question. So if you already have Part D drug plan through Advantage plan, is the Medicare drug plan the same as what you already have?
So the Medicare drugs through the Medicare Advantage plans, everything I said in this applies to that. It applies equally if you have a standalone plan or so the and that's what we looked at in the example. That was a Medicare Part D benefit as part of a Medicare Advantage plan. So yeah, Medicare Advantage plans are absolutely affected by this. In the Medicare Advantage plans, we are seeing higher deductibles and the same changes happening. So all these rules, looking at your formulary, it's important to do if you have Medicare Advantage plan as well. So here's what you do now. Know your plan and its changes. Get your annual notice of change. Get your 2025 summary of benefits. Get your 2025 formulary. Get your list of drugs and go compare them. Or get help from somebody who can do all the math for you. Really encourage people to shop. The plans have changed a lot this year. You really benefit from shopping your list of drugs through every single plan that's out there and understanding the costs. Consider the Medicare prescription payment program if you're in a situation where you have some high cost one-time high costs. And just make sure you're thinking through how this interacts with your other coverage. So your supplements, your MA, like you're trying to make a decision about what to do for the next year. They're all interrelated. So Part D is just part of the whole calculus. But definitely, if you're going to make a change, don't miss the December 7th enrollment deadline. This year, there are half as many days after Thanksgiving than there was last year because we have a late Thanksgiving and people in this industry try to often wait till after Thanksgiving. Our team's getting really booked up. I would call and get an appointment for late October, early November, beat the rush if you could possibly do that. And like I said, we do this every day. We have a whole team of experts that do nothing but, and walk through. Question about the WellCare plan, call WellCare, go to the WellCare website, go to medicare.gov. They can definitely help you understand that plan. And then you either look at medicare.gov or work with a advisor who can help you really understand all your options. So this is the last slide here.
Yeah, thank you, Scott.
And I'll say, so Keen, which is my agency, we just merged with a slightly larger agency, also mission driven, called Connie Health. So when you call us at the 617-213-6694, you'll probably hear the word Connie Health. We're one and the same. And I was doing these slides this morning. My daughter wanted me to put a heart next to the turtle, so that's why there's a heart next to the turtle. Happy to answer any other questions. Happy to hang out and answer a few more questions if you guys want. But yeah, we'd love to help each of you with a personalized consultation. You can call the 617-213-6694 number, or you can book an appointment online at the link here, which I know the team will send out. And I love talking about this stuff, so I could go all day, but hopefully this has been helpful in terms of helping you guys, understand some of the basics, and will be, beneficial going into the new year.
Yeah, I know we do have some additional questions in the chat that we'll address, but since we are at the top of the hour, I do want to do some PSA announcements. So thank you all. There is a feedback form in the chat. I will send it out again. If you could all fill that out for us, really helps us prepare for additional sessions, and also understand what to do differently next time. Scott will return on November 13th, 5 p.m. Eastern, 2 p.m. Pacific time to talk about hot button issues for this Medicare season. So stay tuned for that. And like Scott said, his team has offered you a no-cost Medicare benefits checkup and consultation. So we'll send it out in a follow-up email as well, but feel free to directly call that number or schedule some time with him too. So for those who have to get back to their evening or day, thank you for joining us. For those who want to stick around and ask questions, we'll be here for another 5-10 minutes. All right, so there was one question around how do we find out about WellCare plans?
Yeah. So if you're on a WellCare plan or you're on any plan, you can call them. You can go to their website. You can ask for these documents. You can go to Medicare.gov, put in your zip code, and you'll get information about the plan. Or you can work with us or any other agent. We've got really great tools to make this efficient and so forth. I see another question that says, I get some of my meds through OptumRx. Being an AARP member, do I know if their plan is changing? I mean, across the board, you can assume all the plans are changing. And OptumRx is the pharmacy benefit manager. They work with United plans, AARP plans. They work with a lot of people, actually. They're one of the biggest ones, in the country. But they're all affected by the same dynamic. $6,000 is going from one pocket to another pocket, and that other pocket, it's coming out of the consumer pocket, or we're putting $6,000 back in the consumer pocket and getting it out of the wallet of the government and the health plan. So they've got to change the rules. It affects everybody, including Optum. Well, the plans that you would get that use OptumRx. Other questions?
There's also a question from Tony around who pays you? How does that work?
So if you're working with a licensed Medicare advisor, we are paid by the health plan. The government sets a rate. Everybody gets paid the same amount. So we get paid the same amount whether, we enroll in Plan A or Plan B, so there's no bias. And that's it. We're paid to also service you and keep you happy year after year after year. We're paid every year that you're a customer, but it's sort of a piece of the system that's baked in. The fees are paid. They're set by the government. They're paid by the insurance companies, and that's why you can get this help at no cost, and you should never be charged a cost. Never should be any cost, no obligation. Everything we do as agents is highly regulated to protect you as a consumer. Every call is recorded. You have a lot of rights, and if an agent is doing their job the right way, it should be a very positive experience. I see Sherry has a hand up.
Yes, I'm sorry. Thank you so much. This has been really, really helpful. I guess I wanted to clarify my question or with that. So I actually have a WellCare plan, so I understand that the agents aren't able to share information about it. And also so that's my Part D, but because I'm just a general AARP member, I've been able to get medication through just being an AARP member, and they go to OptumRx. So I was trying to find out, and when I last called OptumRx, they did not know if they were still going to have that plan available. Again, not Part D, just because I pay my $16 a
Oh, it's like a
18.
discount program.
Yeah, discount program. Thank you.
Okay, got it.
And it saved me so much money. It was great.
Yeah, that's great. Yeah, as far as the WellCare plan goes, I'll just comment because, that's a very popular plan. I put my mom in that plan. They, they took the steps to terminate our contracts. I think they may come back next year, but we have to respect that. It's in some geos, it has remained a low cost plan. In the Bay Area where I am in California, the premium has increased. So you gotta, just know the details. I'm not familiar with the details of the AARP sort of Optum discount program. I'm an AARP member, so I guess I should check into that. It sounds like a good program. But if it's just a discount program, I don't know of any mechanic of this Inflation Reduction Act driven change that would impact that. I mean, maybe there is, but whether it's I don't think, if you think about like a Good RX or there's a lot of companies like that, or the discount programs, they're going to be less affected by something like this than the prescription drug plans are heavily regulated. They're heavily regulated by Medicare, and those are the plans that have to follow these rules.
great. That's very helpful. I also have used GoodRx, and that's been very helpful also. So,
Sure, absolutely. Yeah. Um,
that would be good. I guess I've already filled out my survey, but but for people to make sure that people know about those plans, because instead of paying much more on my Plan D, I went to both of those, and it's been very helpful. So,
yeah.
thank you so much.
Yeah. And that reminds me, like, we're getting to the end of the year. Um, like, if you're on an expensive drug, like, don't buy a 90-day supply in December, because you want that to hit your deductible in January, and the costs are going to be different in January. So definitely, sometimes, uh, people will do these multi-month refills. We're getting close to the end of the year, so really, understand that dynamic. And I know a lot of these really expensive drugs, people do all kinds of things to get them, discount programs, shopping, yeah, offshore. And so a lot of that need to do that's going to go away, because, just a $2,000 limit is so much better than an $8,000 limit. Sorry that your head is spinning, but yeah, we're here to help. Would love to walk you through this stuff, but do take your time with it. It is important. And I'd encourage everybody to get this comfortable with this stuff, get familiar with it, become kind of an expert, and then share it with your friends and family, because there's a lot of people who are going to miss the boat on paying attention to this. Most years, only about 30% of the people even pay attention to this stuff. So you guys are already A students for even attending this, so congratulations. But this year is going to be a year in particular where a lot of people are going to be hurt because they don't pay attention. My husband's Medicare Part D is through my NY City retiree plan, reimbursed. Then is this decision one I even need to consider? So retiree plans are somewhat of a different animal. There are retiree-based plans that loosely follow the Medicare rules, but they also they're less regulated, and there are these group retiree plans, and so they do follow a different set of rules. I would just check with the plan to see, uh, what those changes are and how it works, because it's going to be very plan specific. I don't actually know the answer, and it's a good question. I'll find out the answer. Do the group Medicare plans, the Part D in the group Medicare plans, have to follow this new format? Um, and I don't know the answer to that. That's a good question. I do know that right now, about 9 million people are on these group plans, whether it's an employer prescription drug plan or a group MAPD plan. But yeah, so there are a lot of people on these group plans. They have a different enrollment window. Their enrollment window is not now. They have different rules. So you just want to talk to the group administrator to see if these things are impacting them.
All right. If there are no other questions, thank you, Scott, again.